Did somebody take it? You had a script. I'm so sorry. I'm just like,
It's right here.
oh, I have a script.
You have
I
a
was talking
script?
to the ASPCA woman, and I just lost track.
Oh, it's fine. I don't even know what time it is. Remember, I'm on the East Coast.
0 minutes
Okay.
left. Okay.
I have no idea what time
I'm
it is.
gonna wing it here.
Yeah. Okay. There you go.
Perfect.
We're good.
Okay. Okay. Good morning and welcome to the first. This is not the first sessions of Shelter and Medicine and Animal Care Track, but it is the first sessions for today. My name is Dr. Linda Jacobson. I'm a veterinarian at Toronto Humane Society and also president and treasurer of the Canadian Animal Shelter and Community Medicine Association. And I'll be your moderator for this track today. Some of you may have been in the session with Dr. Elizabeth Berliner from the ASPCA yesterday. She's kindly stepped in to deliver 2 impactful presentations this morning as our previously scheduled speaker couldn't join us at the last minute due to unforeseen circumstances. In the first part, Dr. Berliner will talk about the recent updates on the groundbreaking 2010 ASV guidelines for standards of care in animal shelters. So that's the 2022 guidelines she'll be speaking about. She'll talk about what's different about the new guidelines, focusing on recommendations for medical and surgical programs in shelters. Then she'll move on to discuss how shelters have dramatically improved their live outcome rates in recent years, but the problems that come along with that. Saving animals with complex and serious medical and behavioral conditions can be very rewarding, but can also lead to inadvertent suffering, long stays in shelters, and increased strain on resources. So that talk will address ways to approach difficult situations and decisions while restoring and maintaining a good quality of life for the animals. I really wanted to just thank you so much for stepping in, and let's welcome Dr. Berliner.
Well, thank you all for showing up for a surprise lecture. I will say it's not the first time I've done surprise lectures, so when they asked me, I was okay with that, but I know it can be disappointing if you were anticipating CPR, and we'll hope that no one needs it during the session, and so we'll be okay. So today, I work for the ASPCA. Up until last fall, I was full-time faculty at Cornell University, College of Veterinary Medicine, and I still maintain a courtesy appointment there, so I still do some work at the college. But today I'm actually wearing an additional hat, and so I am also the incoming shelter medicine regent for ABVP, which is the board specialty for shelter medicine veterinarians, and I am also a liaison to the ASV. So I've been very active with the Association of Shelter Veterinarians for years. And so it is the place where shelter veterinarians, it's the organization that represents shelter veterinarians in the industry in the US. Although I want to give a shout out to Linda here, who was organizing the Ontario Shelter Medicine Association, which is now the Canadian Shelter Medicine Association. So super excited to hear what's happening for shelter medicine in Canada as well. So how many of you are well familiar with the ASV guidelines from 2010 and our low budget cover? Okay, so about half the room. And that's about what I'm running into. So I've been kind of on the circuit talking about this at a couple different meetings in the US. And about half the people in the audience are familiar with the 2010 document. And I think that speaks to the fact that it took us a while to revise it. And you'll understand why in a minute as I start to go through that process. But this was a groundbreaking document. So thank you, Linda, for starting us there. Because up until that point in the US, we really didn't have federal level, like national guidelines. And I want to point out these are guidelines for standards of care. They are not standards of care. They are not laws. They are not regulations. They are guidelines meant to advise various municipalities, states, and truly not much happens at the federal government level in the US in terms of shelters. But they are specifically to provide a guidance document. And this was based on the framework of the 5 freedoms. Hands again, how many of you are familiar with that? That's kind of been the go-to, for sheltering and other areas of industry. And I'll show you that we've switched our framework for that as well in the 2022. And obviously, we didn't write this to become law, but it is absolutely informed law. So I think, after the 2000 document came out, it was surprising how many state and municipal governments did reach for it when they were looking to create new laws or guidelines in states. in municipalities. And so as we went to revise it, we became even more conscientious about what we decide to put in here could have some major impacts, not only for animals, but for organizations in terms of making sure we didn't want unintended consequences that we didn't like. So we have a newfangled sort of cover. And this is also my opportunity to say that this was also the first edition of a brand new shelter medicine journal, which was a goal we've been working on for a long time. If you follow shelter medicine research, it's been fairly scattered across many journals and trade publications, and we now have a Journal of Shelter Medicine and Community Animal Health, and this was the first issue in December of last fall. And I always love to point out that kitten and those hands, that's my resident. And that kitten's now like one of the most famous kittens in the US as we go around talking about this, and those are Danny's hands, wearing gloves, I might point out. So how do you revise a guidance document? The ASV Board of Directors formed a task force of 19 shelter veterinarians, some of the original authors, some new writers. Authors were selected from ASV based on a lot of things: expertise, what are your areas you really like? Where do you live, to try and make sure we were representative? What kind of work do you do? What kind of shelters are you engaged with, municipal versus private 501c3s? In the US, we have many private 501c3s and fewer municipal government shelters. And we had some that also work with foster-based. The task force was super nerdy. If you were in my talks yesterday, I described the first thing we do is go to all the nerdy articles and pull everything we've got and what's new and updated, and then try to make sure that we would write what is an evidence-based, updated, and here's a keyword, consensus document. So I'll remind you again, 19 shelter veterinarians. So here's our task force members. You're not expected to see that, but it's a whole bunch of veterinarians with a whole bunch of letters after their names and a whole bunch of opinions, as you can imagine, with the unifying theme being long-standing work in shelters and particular passions in the areas, in the sections that they were working on. And the goal was to create a common set of standards for the care and welfare of companion animals in shelters based on evidence and consensus. Again, you will still note we talked about the title. We left guidelines for standards is still how it is represented. We are not looking to set like some sort of gold standard shelter rules. We are looking to inform how other orgs kind of design their programs. Meant to be a tool for animal welfare organizations and communities to improve their shelter. A lot on facilities and housing, because that is one of the areas where so much has happened in the last 12 years. And it's great. We still have a lot of organizations that need to catch up. I am constantly contacted by organizations that are either renovating or building. It's one of my passions. I love to talk about facilities challenges and ideas, so always happy to chat about that. Looking also to, of course, reduce crowding, stress, disease, and improve the safety for animals, create references for regulations and statutes. We were much more aware of that aspect of the work we were doing than potentially we were at the start. And we wanted it to be a living document that responds to developments. And so part of that is a whole suite of online tools, only a couple of which have launched at this point. I'll remind you, it's a volunteer board of very busy veterinarians who only have gotten busier in the last 3 years. But the idea is that this would be a central document, and then there would be tools and resources added on as time went by. The guiding principle of the document remained the same. Language is almost identical to 2010. It is meeting animals' physical and emotional needs regardless of the mission of the organization or the challenges involved in meeting those needs. So at our base is what is best for the animals. Of course, and if you're in my second session, what is best for the animals also means we have to keep in mind what is best for the organization and the people who work there. But it's not necessarily based on the resources that you have. The guiding principles remain the same. I had something else I wanted to add there, but I'll remember it in a minute. So what's new in the new document? Why bother to read it? There's a lot more pages, unfortunately. We tried to limit that, but it just kept going. But we did switch from the 5 freedoms to the 5 domains. I'm going to talk much more about that in the second session on quality of life and what that means, and I'll talk a little bit in this one. But we did change from the 5 freedoms, which was traditionally about removing suffering, like what do we need to protect them from, to what do we need to provide. and truly create a positive welfare state. We focus the vital role that communities play in keeping out of pets, so a lot on pet retention efforts, intake diversion, the role of foster caregivers. We did not go into the realm of how to structure community programs. We very much forced ourselves to stay in the scope of shelters because that could be its own document and probably will be, right? But it is not the scope of this. We've kept coming back to in animal shelters. We consider foster an extension of a shelter, so foster care does apply. Advancements in behavior. Of all the sections, the behavior section is the most revamped, and I would encourage you to dive into it. And of all the sections, it's got the most appendix items for tools and charts and things that you can use. And then there were 2 new sections, forensics and disaster response, so 2 new things as add-ons. They are not operational documents. None of this is meant to be operational. It is all the why and the what. A lot of the how comes in other forms, and I will talk about resources at the end, I hope, if I can get there. And then the importance of shelters as healthy and supportive places for people. So the public health section in the first document was very much around zoonotic disease. Those pieces are still in there, but also kind of a nod and a look at how do we work with our staff and our shelters to provide more support, a nod to workplace culture, and supporting the well-being of our people. And I'll call out right now, because I might forget as well, one of the things that we kept in mind as we focused on this is ASV is also much more active in writing position statements on an ongoing basis. We put out 4 to 6 a year. I'm also on that committee. And so we were constantly asking ourselves, should this, what we're thinking about at the moment, the concept we're thinking about, should it be in the guidelines, which we're probably going to have for 6 to 8 years before we get to revise it, or is this something better suited for a position statement on ASV, which is a more living document we can change all of the time? We revise those every 4 years. And so alongside this document, we published very recently, I think it's fresh as of this week, an ASV position statement on well-being of personnel in animal shelters. And it is both a position statement and a backgrounder, which has a whole section of evidence-based resources and support for how to do that in shelters. So that piece, although it didn't go into the guidelines themselves, was very much on our minds as we wrote this. All right, so the 5 freedoms. That's where we started. Still an excellent reference, came out of farm animal welfare back in the 60s, has been used across industries, and there's nothing bad about the 5 freedoms. We've walked around reciting them. I was always like, I feel like I need to get it tattooed on the inside of my arm. But freedom from hunger, thirst, discomfort, pain, injury, disease, the freedom to express normal behavior, freedom from fear and distress. But if you really look at this, there's still that question of, even if you check all these boxes, which are not that easy to check in captivity, in a shelter, is that a positive welfare state? Does that animal have a good life? And it just didn't feel like enough just to say, yes, we can check these boxes. And so even though Taco has this enclosure that looks clean and an elevated bed and there's natural light shining in and he looks like he's in good body condition, does that truly mean he's having positive welfare experiences on a daily basis? If he doesn't get out of that cage more than 5 minutes a day, if he doesn't have a lot of enrichment, if he doesn't have social time with friends, whether those are human or non-human friends. And so, Taco's idea of a good life may look like that. And that may not be what Taco is experiencing. And so this movement to the 5 domains approach has happened in other parts of the industry as well. We certainly didn't invent it. And it's the 5 domains model of measuring animal welfare. And it shows up in various forms, but I usually reach for this model from Meller in 2017. And so it lists sort of 4 pillars of nutrition, environment, health, and behavior, and all of those feed into a positive mental state. And so we can look at all of the biological and environmental parameters, but ultimately it is that mental state that is important. And what we are aiming for is a positive mental state. So boredom, frustration, those sorts of things that can still occur even if you have all the other boxes checked, we need to make sure we can address that. Some of that is on an individual level, some of that is population level, and again, that's kind of what the next talk is about. And so if we put these into sort of a hierarchy state, we should be in shelters, have nailed down how to provide nutrition, physical environment, and health, although it remains an ongoing challenge, particularly as we become crowded or particularly as we have workforce shortages. Behavioral interactions, again, so much research in behavior in the last 10 years, so many new things to understand about how animals experience the world and how we can enrich that in ways that make their lives more positive. And ultimately what we're aiming for is that golden ticket of a positive mental state, positive welfare in the shelter. And that's what we kept as we were thinking about every single statement that we wrote. And when I use the word statement, that means it is something that uses our language of ideally, must, should, or unacceptable. And I do cover those definitions in a minute. But we were very clear that anything is a statement uses that language. And then there was a lot of supporting text for anything that we felt was important enough to be a statement. But those were even conversations like, should this be a statement or should it just be supporting text for everything we wrote? So, scope. I'm going to disappoint the rabbit people in the room and other small mammal friends and our bird fans and all of the other lovely creatures that show up in shelters because we really stuck to dogs and cats again. And it's because it felt like the scope. We could just go on and on. So we stuck to dogs and cats in shelters. It doesn't mean that we don't care about those species, and most of what we talk about applies to those species too. And if you are improving for your dogs and cats, that often means that you've got somebody who's advocating for those SMAMs and birds and reptiles that are in your care as well. I will also say that another side project came out of this project, and there are groups working on guidelines for rabbits, particularly around housing and shelters. So those things are happening. Again, we stuck to animals within the care of the shelter and out of scope, community engagement, community programs, because it felt like that was its own full project, other species, and then the how. This is not an operational document. All right, so we started this project in 2019, fall. We had all sorts of plans. We had a 2-year timeline. I'm happy to say we pretty much stuck to that. But we took it all online and had very long Zoom meetings, which was pure torture, I will tell you. But in that time, the world also changed in so many ways, right? So we had a global pandemic, which definitely upped the ante on the role of community programs for sheltering organizations and humane organizations. So we were even more acutely aware of the fact that that was not going to be within the scope of our document. Absolutely racial inequity protests, a lot of things happening in the US and in Canada, a lot of conversations around how we needed to look at our humane law enforcement, our traditional models of policing and law enforcement for animals, and see whether there were other ways to do things that were more interventional. And that certainly was part of our conversation. Again, some of this ends up in various parts of the document, but not completely, I would argue, not as completely as it probably should or could be. But the goal is to, again, put that into its own piece that can be a little bit more fluid than these guidelines. And then obviously increasing climate events. Lots of interest, particularly around facilities, but also around things like sanitation, animal care, medical care. How do we minimize waste? How do we become more sustainable? What are the utilities that we're using in our various organizations? How do we build greener shelters and greener organizations? That also somewhat out of the scope, but certainly informed the work that we were doing. All right, so the way we structure it, we have key actionable statements. Unacceptable indicates practices that need to be avoided or prevented without exception. We were very choosy about what becomes unacceptable. But there are, I think it is the facilities section that probably has the most unacceptable. I don't know all of the metrics off the top of my head, but my editors did. Must indicates practices for which adherence is necessary to ensure humane care. So we feel pretty strongly that if it's a must, it is a must. Should indicates practices that are strongly recommended, and then ideal indicates practices that are implemented when resources allow. And this is absolutely a nod to the fact that all of us work in a very broad, diverse group of shelters. We know that there are massive differences between organizations in terms of size and in terms of resources, in terms of community sort of input, all of those things. And so again, our guiding principle is always the welfare of the animals first. It does mean in some cases that some of our statements may actually, in the US, I run into that some of our statements actually go against regulations. They are actually in opposition to. So we debated that, and we're like, our principle is always animal welfare. And so there's one statement at the end of management and record keeping that I advocated for over and over, and we finally did include it, that it says, if these guidelines are not aligned with regulations in your area, we advocate that you attempt to change those. This idea that we want shelters to work within the law, and we very clearly call that out time and time again, that you need to work within legal frameworks. However, we're still going to stick to the principles that are best animal welfare, and sometimes those aren't aligned. I don't know if you've run into that, but I certainly have. All right, so building a consensus document. 19 shuttle veterinarians sitting on Zoom calls. So we don't even have like body language or like breaks to talk to each other. Getting consensus was pretty tricky. So I'm gonna ask all of you, when traveling back in time, and don't raise your hands yet, would you prefer to travel to the past to have more impact, or to the future to have more impact? Choose one. All right, who thinks they could have more impact if they travel to the past? Who thinks they could have more impact if they travel to the future? Oh, about half and half, look at that. Is anybody willing to defend their position? Yes. So by going back in the past and having impact on legislation, you could essentially go back and change so that you could have better policies now. So going back would be helpful. Excellent, I love that point of view. Who wants to defend their future? Point. Nobody? Oh, you won. You have convinced everyone now. No one's gonna argue with you. Yeah.
If you're working on the future, you can look back at the past and see what mistakes were made and correct them.
Ooh, good point. So you're informed by the past as you travel to the future. Excellent, good point. All right, has anybody been swayed by either of our speakers and potentially would be willing to change their mind? No? So then this is kind of how it went. Then we would be like, is anybody willing to die on this hill? Any of you are like, I would never go to the past. I would never go to the future.
I have no idea which one I would do.
Okay, and that's fair. We had that response too. But this is kind of how the process went. Like, oh, I'm swayed. Oh, I'm not swayed. I am willing to die on this hill. I was willing to die on the hill. We had to use an Oxford comma. True story. Oh, my computer's not here, but it has a sticker to that effect. Because I was like, there's no Oxford commas. I'm out. I'm done. But for most other things, I was a lot more collaborative than that. All right. So we can skip this because I'm chatting. So unfortunately, we have 13 sections, which is neither graphically appealing nor a good number, but that is where we ended up with 13 sections. So management, population, animal handling, facilities, sanitation, medical health, shelter surgery, forensics, behavior and mental well-being, euthanasia, animal transport, disaster response, and public health. And in this particular session, this is kind of the three I'm gonna hit on the most. So management, record keeping, medical, and shelter surgery. All right. A lot in this section, management and record keeping. I know it's really sexy, right? Like how many of you are like, I can't wait to read that section because I wrote that. Okay, good. I got one fan. Two, when I got assigned that, I was like, really? That's my section? But it's really sexy. You can't do any of the other stuff unless you do this stuff. So it's section number 1. I'm gonna call that out. So a lot of it's about decision-making. So we very much still spoke to the fact that decision-making must take into account resource allocation, as well as population and individual animal health and welfare. How many of you find yourselves in these scenarios where you've got the cute animal, individual animal in front of you that is just like pulling at your heartstrings, but you're also the person responsible for the budget, and you know what your resources are, and you also know that your staff is really strapped right now and may not be able to extend themselves, and then you also field your social media and you have concerns about what's going to come from there. How many of you are in that web? Yeah, quite a few of you. And so it was a recognition and trying to call out that those things matter, that we need to remember all of those facts around that individual animal, which is often where the focus is for people who get into animal welfare, particularly if they're fresh to the field. And so that kitten, that snotty-nosed kitten on the cover is the focus, but there's so much around that individual animal decision that needs to happen. We wanted to call out that the allocation of resources are best made by personnel aware of the priorities and the shelter's capacity for care. And so some of this is speaking to what is sometimes tensions between veterinarians and admin. I'm just going to call that out, right? Because veterinarians may be making decisions based on medical principles they learned in vet school that are very individual animal based, and organizations are making decisions based on budgets and staffing. And so some of you are nodding, you know that's an area of tension at times around decisions. And so we wanted to kind of give a nod and recognize that these decisions are complicated, but it is really important that there is input from people who understand the budget and the resources, but also people with the expertise in various areas. And there's another statement to that effect. That decisions really need to be made along certain authority lines by people who have the information to make them. And so it's about kind of how you organize that process. I'm not completely familiar with how veterinary practice acts work in Canada. In the US, they are state-based. It is very confusing. And so you are licensed in the state and you follow your state's practice act. And if you want to practice in another state, you have to get another license, and the practice act is different. Okay, so you're nodding, very similar. Similarly, the role of paraprofessionals, the role of technicians is very different. In some states, they must be licensed, and in other states, there's no licensing process at all. There's no title. And so this gets extraordinarily confusing and makes it really hard to write a document on management and record keeping that is supposed to represent all of the states and all of the roles. But it did, and we're also at a point, I'll remind you of the context, where telehealth became much more active during the pandemic. We started to realize all the various ways we could use it. That is an ongoing conversation nationwide and in various states. And so we did call out particular recommendations. They are not statements, but they are recommendations that telehealth can be really useful in extending access to care, both for shelters and community animals. And similarly, we have some specific practice activities around dentistry and surgery, practices which also go by Practice Act and are different in various states. We also speak a lot, and it's going to come up in this, about oversight, veterinary oversight in terms of medical policies and procedures. So that's probably on our next slide. So this was a big step and not an easily accomplished one in orgs. So I want to say that there are lots of orgs in the US that do not have formal relationships with veterinarians, or those formal relationships are old, dated. The veterinarian signed a piece of paper 10 years ago and hasn't been back to the shelter since, but their name is still somehow on all the accounts. That happens. Yep, okay, we have the same. But we really wanted to try to push the needle a bit with veterinarians and with shelters to say that a formal relationship must be in place to ensure oversight and medical surgical care in the shelter. That does not mean the shelter has to employ a veterinarian. There are various ways this can happen: board members, volunteers, use of private practices, contract veterinarians, or employees. I will say that the push in the states has been more to look at employing veterinarians and organizations, because at a certain tipping point, it becomes a more economical choice than farming out to private practices. It also allows for more continuity of oversight, because most shelter veterinarians automatically take on some sort of medical management role, an oversight role, if they are the only veterinarian in the building, or if there's multiple veterinarians, one of them takes on that role and then other vets or associates beneath that. And so that is fairly common, to have a veterinarian who, it might be a contract basis. We do still have states that will not allow shelters to employ a veterinarian. That still exists. It's less common, and I'm kind of amazed when I run into it, but I ran into it recently. My current role is more of a national role. I do a lot of consulting with shelters and talking to shelter veterinarians. It's an amazing job. I'm super fortunate. And I ran into a state where their Practice Act actually includes making any recommendations around medical care. So even for me to make a recommendation to a shelter in that state is considered practicing veterinary medicine, and I can't do it, which was really, that's the strongest language I've seen. Fortunately, it's not that common, but we do still have those issues. Again, as we're writing these recommendations, we are writing them to what we think is best for animals. And so in some cases, not necessarily what's in the regulations or the current system. In terms of organization and oversight, we are a big fan of protocols. That probably shouldn't surprise any of you in shelter medicine. We have an appendix. Appendix B is an entire list of the protocols that we think are core in shelters from an operational sort of management standpoint. And the shelter's veterinarian should be consulted on policy and protocols that relate to medical and behavioral animal health, is where we landed on that. So if you need a quick checklist of like what are the protocols that should be in place, flip to Appendix B in the back. And that can help you get kind of a starter list. This was one we talked about, I don't even know, a really long time, and it's one of the few statements that has two statements in a single sentence, and they are at different levels. So a shelter's veterinarian must have knowledge about the population and should have training or experience in shelter medicine. We debated this for a long time. Knowledge of the population is a broad definition. They've been to the shelter. Timely visits. We argued about time a lot in this document. What is timely? But timely visits, they understand the husbandry and they have signed off on the protocols for medicine, is what we expect as knowledge. So that's a must, and we felt like that was like you can do that, even as potentially a volunteer or board of directors veterinarian. And then training and experience, it doesn't have to be a residency, an internship, even an online coursework, graduate certificates. All those things exist that didn't exist in 2010. But more and more conferences like this, online CE, you can get shelter medicine training and expertise pretty quickly, and it's mostly free and online. We also have core textbooks now. And so we felt like we could really say to our colleagues, if you're a veterinarian working in a shelter, at least try to get up to date on some of the materials about shelters. It's a big ask, especially if they're volunteers, and we know that, and we want to make it as easy as possible, but that was the goal. And it was fairly, I wouldn't say it was controversial among our own group, because we're all shelter veterinarians, but we were aware of how controversial it was in stating it, because we certainly don't want to discourage private practitioners from working with shelters. We absolutely need them to, but we also wanted to kind of make sure it was clear that this material is accessible. And vets like me, my whole job is to talk to veterinarians working with shelters. That is my whole job at this point. Well, I shouldn't say that. The A would probably disagree with that. They have a few other jobs too. But that is what I do a lot of and what I really love to do. All right, so let's talk about medical programs. And we're good on time. Look at that, I'm doing all right. So core stuff for the medical program, and a lot of this really does fall to the veterinarian. This is the area where veterinarian approved protocols were super important, and supervision of trained medical staff is part of what we ask for. So it includes histories, exams, preventive care, and pathway planning, all as essential components of a shelter medicine program. So when it comes to history and initial exams, and I should have said at the beginning, anything in a box in italics is the language straight from the guidelines, because guidelines are kind of like law. Every single word matters, and I don't want to do my interpretation of what the statement was. I want to give you the statement as it is, because it's really easy to change the meaning by changing a few words. So each individual's individual health status must be evaluated, documented, and monitored beginning at intake. So how many of you currently have a system that allows animals to be checked in at intake and be examined by a trained medical staff member? Does not need to be a veterinarian. Perfect. Okay. That is the system we're going for. It is not a vet standing there. It is a trained medical staff member, and that does not have to be a technician necessarily. I don't think there's any state that requires that to be a technician. So trained medical staff member. We struggled with the language here, but each animal must receive a cursory health assessment by trained personnel at intake to check for signs of infectious disease or problems that require emergency medical care. So making sure that our trained medical staff members have the ability to triage an animal and recognize pain and a need for emergency medicine. The scope of this exam is also doing things like capturing identification that can go into lost reports for strays, for instance. The sex of the animal, age, weight, physical description, infectious disease signs, and emergency issues. And this is a hot topic right now where I live. I'm in upstate New York, because New York just passed a law last year that incorporated some of the 2010 guidelines language into regulations. We haven't had regulations around shelters other than for animal control. And so this language is now actually getting incorporated into New York state law, and we are just at the point of figuring out how do we now train everyone working in all of those organizations to have somebody who can do this at the point of intake. So as I was working on this, I was also acutely aware of how it was going to be applied right around me. In very rural small shelters, potentially animal control facilities that are contracted dog wardens, because we do still have that model, and how to actually help implement this and make sure that people can stick to it. Preventive care. Shelters you can't see that. Shelters must provide species-appropriate preventive health care, implementing protocols that strengthen resistance to disease and minimize exposure to pathogens such as vaccination, parasite control, good nutrition, appropriately handling, and housing location. And so really speaks to, if you go through the text, again, it's not operational. We're not putting doses in there. We're not telling you what products to use because there are other resources for that. But this is what's expected. Core vaccinations at intake. And we do call out modified live vaccines. We do call out what is core in shelters is different than what's core in private practice or in some of the other guidelines that are out there. Antiparasitics. This was an upgrade, so the 2010 required deworming at some point before adoption. Now we've upgraded that to at intake with a basic broad spectrum dewormer for roundworms and hookworms, which in my world is pyrantel that costs like pennies. We do not have anything beyond that as a minimum guideline. Obviously, it's lovely if you can go beyond that. Housing, there has to be isolation housing for sick animals. There should be quarantine housing for holding animals, although quarantine is not standard for all animals, only high risk that had exposure, potential exposure. Gen pop sort of housing, and then foster. And then pathway planning is essential part. So fast track, how many of you have heard that pathway planning, fast track, slow track language? Okay. And so it speaks to the fact that when an animal comes in, if they're a cute, healthy kitten, they're 8 weeks old, they are a good body condition, they are a fast-track animal, they need to get spayed, neutered, and out the door. Versus you get an animal in that's got injury, infectious disease, other comorbidities that's going to take longer, that's a slow-track animal. And they may have a slightly different pathway. Doesn't mean you're going to not treat them. You can treat them, but you're very aware of the fact that fast-tracking these highly adoptables does not necessarily negatively impact the rest of the population. It actually helps because you get them out. So you've got fewer animals in your care. And so that sort of thinking is part of preventive care in the guidelines. There's a vaccine schedule in there. I won't go through this in too much detail. You can always look at it. But we did call out what was core in shelters, which again may not be the same as in private practice. Monitoring. So we did call out a few things that were essential for monitoring on an individual level. So monthly weight and body condition score, an exam at least every 6 months, and then more often exams with chronic issues. And then on a population level, daily observations of all animals and population rounds. So that combined medical behavioral operations approach to walking through the population. I'm actually going to talk about that in the second section on quality of life and decision making, because that's a huge piece in decision making. Trained personnel must visually observe the health and well-being of every animal at least once every 24 hours, and a medical staff member should attend population rounds with representatives from other departments. It's not just medical rounds, it's medical sheltering behavior rounds. Population trends. We talked a little bit about software yesterday, and we did put in as a should that shelters should track animal population trends and develop targeted strategies to address concerns. We did give a nod to the fact that there are still some shelters in our area working on paper records, but really kind of encourage them in the supporting text to make the switch to electronic. It's a lot easier to pull population level reports. It's not perfect, but at least you can pull some levels of intake and outcomes. You can track some conditions in your shelter. It does help to have early recognition and look at trends over time in your organization. It doesn't have to be perfect data, but at least if it's in a software system, you can pull it faster. And so that was a goal. We argued a long time about whether we were going to require people to use software, and we went a little softer than that. So as long as you can pull population reports, you can still use your paper, but hop to it. I'm in the process of trying to get a grant for a really small organization in Ohio that does not have computers, and I did this lecture in Ohio, and the the shelter manager came up to me and was like, I just need a computer. Like, I don't have a computer. And I'm like, okay, we got to work on that. So that, I know those orgs are out there. She was working so hard. Shelters must have a means of isolating contagious diseases. That can be on-site, that can be in a clinic, that can be in a foster home. All of those things are possible, but remember, isolation is for sick animals. Sick animals need to, in most cases, be out of your general population, and a shelter needs to be able to isolate them. I go to shelters that have like designer isolation wards. They have like 3 dog ISO wards and 3 cat ISO wards, and that's what the textbook says. I also work in shelters where this means we're gonna throw up a shower curtain or we're gonna retrofit a part of the building as an ISO. So you've just got to have some place those sick animals can go. And then we also had other options about informed adoption. Maybe they need to just get adopted as is with a disclosure, transferring to other orgs that potentially are better suited to handle that infectious disease, or euthanasia if these options are not humane or possible. And allowing, this is one of our few unacceptables, allowing animals with severe infectious disease to remain in the population is unacceptable. If you have an outbreak, you kind of need to know what to do, and you need to be able to separate animals. So again, this often doesn't mean that your facility is set up for it. It means you need to strategize around it. And so this is a big call out to say that if you're having an outbreak, you need to be able to recognize it, so a rate of disease higher than the norm, and then start to think about how to strategize separating those populations and doing a risk assessment. And this is also when I say that there are people like me who this is my whole job, is to pick up the phone and help you. So academic programs in the US at Wisconsin, Davis, and Cornell all have interventions. The nonprofits do as well. So ASPCA, where I work, we have a consult line and can help with these. Best Friends has veterinarians working on this project. At OVC, they will take consults now through Thank You. I'm going through the list in my head, so I'm not leaving you out. I actually tried to collect. I have 23 groups on a list. Some of them, Jyothi out in California. So there are lots of people who can do this, and you're not alone. Pick up the phone and call, and we will try to help. You need an emergency plan. It doesn't mean, we didn't try to tell people what that plan was. We were just like, you need to have one for animals that if they are in an emergency setting, the trained medical staff member doing their exam needs to triage. They need to be able to recognize an emergency, know who to report it to, how to access services, and this includes provisions for animals in foster care. So if they are under an emergent situation, there needs to be a formal process that's in writing that people can follow so that those animals can access care. All right. Shelter surgery. How are we doing on time? We're doing all right. So shelter surgery, in the 2010 document, it was called the spay-neuter section. And we would love to have stayed there, but shelter medicine didn't stay there, and so we had to bring in some other surgeries into the shelter surgery section. Having said that, there's an entire textbook on high-quality, high-volume spay-neuter and shelter surgery. So if you're not familiar with that, it came out from Wiley-Blackwell a couple of years ago. So there's a textbook about this thick on this topic. And so again, ours are just sort of guideline statements, but not operational how-tos. Shelters should sterilize all animals before adoption or ensure they will be sterilized. Again, we're not telling you how. We're not telling you you have to call people. We're not telling you you have to use a voucher system. We're not telling you you have to enforce it. But you should try to have a system for ensuring they're sterilized. And if they don't have the capacity to sterilize all animals prior to adoption without increasing length of stay, an acceptable alternative is to arrange post-adoption spay-neuter. Lots of conversations around this language because in the US, you can almost draw a line across the center of the country where there's access to spay-neuter in the north and no access to spay-neuter in so many parts of the south. And that's not entirely true. There's also certainly areas in the north that are struggling, particularly now. But we had lots of conversations around the fact that we still wanted to make sure that we were indicating how important this is. Obviously, there's the ASV veterinary medical guidelines for spay-neuter programs. It has its own set of guidelines, and that's published in JAVMA from 2016. Well, every time I say that, I'm like, 2016? At some point, that needs to be rewritten soon. As far as I know, they're not organized to rewrite it yet, but I will say I use it, and there's a rare moment when I see something that I think, oh, that probably needs to be updated. That is a very current document to date. Those things have not changed as quickly as shelters have. Pediatric spay-neuter, greater than or equal to 6 weeks and greater than or equal to 1.5 pounds is where we fell on that, and that is in line with other guidelines. In terms of other surgeries, all surgical practices and protocols must be developed in consultation with a veterinarian familiar with the sheltering organization, its population, and its facilities. And so we are very aware that a lot of shelters have brought into their spay-neuter suites other procedures. I am very aware because I do them too. Dentistry has ruined shelter medicine for me, personally. But a lot of shelters are doing fracture repairs, leg amputations, enucleations, eyelid repair, and dentistry. Dentistry is the second most common procedure in the organization that I worked in for the last 12 years. And so it is absolutely a balance of impact on welfare and adoptability to do these things, but we also wanted to call out that you've got to pay particular attention to pain management. You've got to pay attention to the protocols that you're using. So particularly if you've been living in the high quality, high volume spay-neuter world for a long time, we're very protocoled, and that's how we make it happen. But we sometimes have to remind ourselves that an amputation is a different procedure. It might require a change in our anesthesia protocol. It's going to require a change in our pain management protocols. And so those animals can't just hit the same box as the 10-minute dog spay. There's other things we need to take into account, and that can include timing. I can't tell you how many people have said to me, can you just come up with high-volume dentistry? I need a 10-minute dentistry procedure. And I'm like, what do I look like? We have not mastered that, and I don't know that we will. We called out a few things specific to dentistry, because I think it's the second most common procedure at this point, and I don't have evidence for that other than my anecdotal experience in talking to shelters. Dental procedures, including radiology, must be performed by appropriately trained and credentialed individuals based on state and local regulations. Medical exams should document the dental exam, diagnostics, and treatments. Non-anesthetic dental probing, scaling, and polishing is unacceptable, one of the few we have in the medical section. Intraoral radiographs are ideal, is what we included. There are states in the US where veterinary practice acts are pushing that if you're doing dentistry at all, you have to do full mouth rads. That's a thing. And that's running up against the sort of interventional dentistry that we're trying to do as a welfare issue in shelters. So I have not encountered that myself, but some of my colleagues have in other states. And so that's where we fell in the conversation. There's two approaches to that. In some cases, they stopped doing dentistry. In other cases, they've gotten really good at taking full mouth rads. So the other approach on this is figuring out the money and then training technicians who can do a cat mouth in 3 minutes and a dog mouth in 7. And I've seen it. It's pretty impressive. But obviously, that's a really well-resourced shelter that also has technicians can do that kind of higher level interventions. There's going to be a lot of arguments in my world about who gets to do extractions and that sort of thing. So that's coming down the pike for sure. Pain management. So pain management will be recognized and treated to alleviate suffering. Protocols for the treatment of painful conditions should be created by a vet, and failure to provide treatment for pain is unacceptable in a shelter setting. And this is recognizing that we treat a wide variety of species. Individual animals react differently. We did stick with the underlying idea that if a procedure, injury, or condition is known to be painful in people, it's probably painful in animals. And then again, on an operational level, referred people to many of the pain scales that are out there. So I have it in the next session, but the Grimace scale for cats, the Glasgow scale for cats for post-operative pain is a really good one. They have a similar scale in dogs. Like, we have tools now to be able to measure pain in animals, and part of that is translating that to the shelter setting. And then medical decision-making. This is kind of where we started. Individual animal health needs to be addressed within the balance of decisions, and the shelter's capacity to provide care is about resources to safely and humanely provide treatment, the number of animals we're seeing, the likelihood and consequences of disease transmission, the likelihood of recovery for an animal, and the animal's potential for a live outcome. So we make these decisions every day, and they're difficult decisions, but we've got to keep all of those things at play. And then finally, in terms of rehoming, we have a strong commitment to written disclosures and waivers. making sure that we're documenting the conditions of the animals and that people know what they're adopting. And I think this just makes sense, that it is fine to adopt out medical conditions and behavioral conditions in your community as long as you're forthright about it and you've got it in writing. And I'm looking at my friend Linda because I think she has continued to have the largest library of medical disclosures I have ever seen, and she shares it freely and willingly with anyone. So I love that, and I have definitely used some of hers as baselines for our own. So ultimately, in summary, in terms of the medical program, comprehensive medical programs are kind of key in shelters. The shelter medical care begins at or before intake, including if you can vaccinate prior to the animal ever showing up. When a shelter admits an animal, they are taking responsibility to find a humane outcome for that animal, that it can include euthanasia. Decision-making is always at the intersection of population and individual health, and protocols help us be efficient and talk to each other and potentially find consensus before the emotional moment of having to make those decisions. So this seems overwhelming. It would be even more overwhelming if you were unfortunate enough to sit through the 8 hours of talks that I pulled this out of, because people have had to do that. We really encourage sort of a setting priorities approach, taking a look at the unacceptable, and I will say all of the statements are published in a PDF form, a checklist by section. So looking at the unacceptable ones, addressing those first, then look at your musts and shoulds and figure out what you can do fairly quickly and easily for your organization, and then addressing the ideal statements as you can. There are tools. I already referred to the checklist that's online. What is coming is a sortable spreadsheet in an Excel file. I'm waiting really anxiously for it because I needed it like a month ago, and it's not quite ready. But that is coming. And then additional tables, decision trees, sample protocols, and lots of guidelines and action sort of case examples. A lot of this is continuing on the ASV webpage, is where everything will be based and where a lot of the follow-up webinars and things will be discussed. And I referred to our textbooks on an operational level. If you're doing shelter medicine on a regular basis and you don't have these books on your shelf, it's time to ask for $500 and buy these books. You can get some discounts at various shows, but that's the library. And I will say the blue one on the end, which is the core, that was a second edition, was 2013. That is currently on my desk to revise, but it's going to be at least 3 years. So that one's still good, but there will be a new edition of the shelter medicine book on your far left coming down the line. Ultimately, ASV, it's more than the guidelines. We do write position statements on an ongoing basis. We're always taking ideas for new position statements. Right now, we're writing one about needing to support shelter medicine education at veterinary colleges as essential. It's a little pet project of mine. And now that the well-being one is done, is feeling good. The other one that's coming out fairly quickly is considerations for animals as live evidence and needing to expedite cases because they shouldn't linger. That is also coming. It's under legal review. Are we done? Am I over? I'm so sorry. Somehow I got off time, so I apologize. It's all one? Oh, okay. Okay, so that's the end of part one. Any questions that I can take? And if I held anybody up, I'm really sorry. Feel free to go skipping out. I know I didn't get any, usually I get the mad waving and the... I was only at 50 minutes on my timer, so I thought I was okay. Did I have an hour? I didn't have an hour? Oh, got it. No. Okay, that's all right. Yeah. So I should just start whenever people are seated? Okay. You have a question? I'm scared of your questions. Yes. Oh, okay. Yes, please do. Please do.
Yeah.
Let's be sure.
All right. Thank you very much for being here, and for those who were here for the last talk. I just wanted to explain what's happening here. So the CPR talks were unfortunately cancelled for reasons of, personal reasons from the speaker, and Dr. Berliner has very kindly filled those two gaps for us. So she's just spoken to us about the new ASV guidelines, and the next talk is about decision-making in animal shelters. So if you are here for CPR, I'm really sorry. The talk's not about CPR, but it's going to be amazing anyway. And then in terms of questions for the previous talk, did you want to take one or two questions now?
Amelia,
or
can I take it at the end?
do you want to take them at the end? Okay.
Or at lunch? Okay, okay. All right, so I really need to change these pictures because I chose these sad pictures when I first wrote this lecture, and truly this is not a sad lecture. But this is a passion project of mine. So I think I wrote the original version of this talk in 2015 and have continued to update it as we go along. So for those of you who were in the first section where I talked about management and record keeping being the piece of the guidelines that I got, in some ways I was really grateful for that because I think how we organize our shelters from a management standpoint and from an operational standpoint plays such an important role in the day-to-day decision-making that we have to do. And so much of that is dependent not only on the systems we have in place, but the communication that we have among departments and between staff members. And I consider those things to be really important in terms of how they overlap. Because a really good system can improve your communication, and good relationships and communication can improve your system. And similarly, if one of those things is not so great, it can fall apart pretty quickly. And I've learned this over the years through experience. And I'm not going to say that any shelter has the perfect system, but I want to share some tools with you that I think are really helpful in these scenarios, particularly if you are in an org that is struggling around decisions or struggling around departments being siloed and potentially conflict around decision-making. So those of you who are with me, you saw a different version of this in the last talk. I actually stole this from Rachel Finney at Columbus Humane in 2010, because she did a lecture and was like, I know you're all out there making decisions about kittens, like individual animals. But the truth is that every decision you make, you have to think about your organization, in terms of your organizational health, your finances, how you all work together, all of the various people, and you have to think about your people, from the people doing that daily care to the people who are making all those big decisions, and the people in your community. And so as animal people, we get into this because of that kitten, but there are so many components that we need to address in order to be effective at what we do. This is the parallel to the speech I give students who want to apply to vet school. I'm like, if you're applying to vet school because you like animals more than people, you're doing it wrong. Because you are not going to be able to help animals without helping all those people. So let's get into a little bit of the background around quality of life. And a lot of the language, the definitions, the research that we have is based in human healthcare, because we've cared about human quality of life longer than we've cared about animal quality of life. But this is the definition from the World Health Organization in 1996. Quality of life is the individual's perception of their position in life in the context of the culture and value systems in which they live and in relations to their goals, expectations, standards, and concerns. It is a highly individual sort of construct that varies from individual to individual based on all of those factors. So do I have any, I'm going to use my favorite example, marathon runners in the room. Oh, okay. So you probably think your quality of life benefits from running marathons, right? Because you really enjoy it. And so it enhances your quality of life. Personally, for me, that is my idea of hell on earth. Like, there is no way that that would enhance my quality of life to tell me to run a marathon. And so you can look at all kinds of things. When I talk to vet students, I'm like, why in the world would you sit here for 4 years suffering through listening to people like me? Like, is that a good quality of life for you? But for them, it is attaining a goal that they've wanted maybe for their entire cognitive lives. And so quality of life is highly individual for people and probably for animals. So highly individual construct. What we also know in people is that it changes over time. So how you might define a good quality of life for yourself at 13 is different than 31, is different from 81. So that way of how you perceive your own life shifts in response to the things that you experience, and you can recalibrate. So they have studies in people who have had life-changing accidents, And what they might have described earlier on with quality of life might have been athletic events or things that they could do. And then afterwards, they recalibrate. And so different things become more important, or they change what their events are and choose something different. All of you probably have an example of something that you were once so passionately committed to that you felt like it was like the best thing in your life, and then you may have given it up over time because you found other things that also gave you that degree of pleasure and made you feel like your life was high quality. So we can recalibrate, we can reprioritize. It absolutely encompasses more than physical health. So there's a lot more involved in looking at what makes the quality of life a good quality of life for people. It's physical, mental, and social connections are super important for people. And it is a spectrum of experiences. So it's not like you score a certain score and boom, you've got good quality of life, or you're 3 points below the score and you've got poor quality of life. It is a spectrum across a wide range and can change day to day, depending on what's happening. In human healthcare, there are some easy sort of surveys or tools that are used commonly for people. So you can look at physical and mental health, you can look at health risks and conditions, certain diseases. Functional status is a big part. So can people do what they want to do? If they can maintain the function that they want to maintain, they report a higher quality of life. If they are functionally challenged, they tend to report a lower quality of life. Socioeconomic status. Money can't buy happiness, but it can buy things that buy happiness. So there is an element that your income matters at a certain point. Doesn't mean that more money necessarily makes you happier. I think we all have plenty of examples that that's not true. But at least having a socioeconomic status that allows you to have basic functions and maintain a life that you consider quality is important. And then social support. So I'm sure you've all seen the studies, particularly during the pandemic, we talked about it even more, that the social support for people is huge in how they see their life in terms of whether it is quality. And there are various measures that you can go online and do. WHO has one, CDC has one related to diseases. And one that I've seen commonly used now in our industry is the Pro Quality of Life score, and that is a tool for care providers specifically, nurses, doctors, veterinarians, animal welfare personnel, to assess themselves and others in care professions, because so much of what we may see as our role and our identity is providing care for others, that this actually speaks to looking at your quality of life in a setting like that, particularly around compassion fatigue, secondary trauma, and burnout. Technology doesn't always mean improved. So medical miracles and medical developments are certainly important. Veterinary medicine has lagged a little bit behind human health care in this, but it's becoming more of an issue that we may have increased technology to help our patients live longer, but does that living longer actually translate into a good quality of life? And so the field of medicine is evolving rapidly. The access to specialty care, tertiary level care, quaternary level care for pets is certainly growing. Our academic institutions are driving that for sure with discovery, and it's important. But there is this same sort of tension that can pop up in our animal populations, our pet populations, that we see in human healthcare. And I'm assuming, I won't ask, but most of you, if you're of any age where you've worked with family members or friends who have had serious illness, have probably found yourselves having some of these same conversations around the quality of life of your loved ones as they struggle through terminal disease or debilitating illness, because this is obviously an area that's pretty active in human healthcare as well, in figuring out how we do this in ways that are humane for people. And it's the same questions we have for animals. When we look at animal quality of life, the original models and kind of thinking about this, this is a 1997 model, which we still use, is looking at sort of 3 domains. So our physical domain in terms of comfort, discomfort, fulfillment, and fundamental diseases and medical health. Our mental domain in terms of emotional health, control over one's environment and social relationships, and then our natural health. So compared to animals in the wild, how are these animals in our captive settings? And I refer to shelters as captive settings, like zoos and laboratories. It's the same sort of idea. We hope a short-term one. But all of these pieces we can use to say, okay, how is this animal, is this a quality experience that they have? I want to call out under the mental domain, control over one's environment has been demonstrated time and time again to be super important in lab and research settings, and some limited research in shelters. Giving animals choices about where they rest, about whether they can hide or not hide, about whether they want to be elevated or on the ground, about whether they want to be with a friend or not be with a friend, about whether they want to be seen, what they want to eat. Giving choices, we do believe, enhances their quality of life. And then trying to look at what those preferences are and trying to meet those preferences for those individuals within our populations. So the most reliable form of assessing quality of life for people is self-reporting. There's nothing better than a person who can just report how they feel about their quality of life. And when that is put up against objective measures, there's really nice alliance. I can't ask these lovely Chihuahuas how they feel about their quality of life, right? They're not going to tell me, although they might tell me in other ways. And all three of these lovely creatures were strays that came into the organization where I worked. The one in the middle went home with me for many years. I took him home and I was like, this is a short-term commitment. This dog is really going to die. And he was really mean and he lived a really long time. And I loved him like nothing else. He went all over the country with me under my airplane seat for years and bit people in all kinds of states. But he had no jaw, so it was fine. So we'd love if these cranky dogs would tell us how they feel, but they're going to tell us in other ways, like snarling with their little cartilaginous proboscis that they were left. We need to use proxy, right? So we've got to figure out things that we can use as proxy measures, and most of these are going to be things that we can observe and then interpret, which is fraught with peril, because we will be interpreting and we will not necessarily be objective in that. But we want to try to figure out what tools can we use. And so this is going to be based, if you're thinking from a medical standpoint, physiological parameters, heart rate, blood pressure, cortisol measures, all of those things apply. And from a behavioral standpoint, what are they actually doing and demonstrating to us? And then what does that interpret to? So who's the proxy for the companion animal? For owned animals, who's the proxy? Owners, absolutely. Anybody else? Vets, yeah, I think both of those people play a role. And then there's usually other people who might want to stick their nose in and be proxy too, right? So, but it's, as a veterinarian, it's a little, I worked in practice before I went back into shelters. And yes, it was always complicated. Those decisions are complicated, but we had sort of a limited pool of proxies. How about in a shelter? Who are the proxies? Staff. The list is a lot longer, right? So we've got directors and care staff, veterinarian, volunteers, board of directors, foster owners, social media, people in the public, adopters. It's a really long list of proxies. Do decisions get easier or harder the more people you add in, right? So yeah, this becomes a lot harder process, which speaks even more to needing to have tools that we can all agree on and a process that we can agree on. In addition to sort of that domains approach for the individual animal, I think it's also helpful as we're trying to think about how do we make group decisions around quality of life and outcomes to have a philosophical sort of framework too. And I reach for this a lot as I'm thinking through. So these are three that have been applied from human healthcare. One is the objective list theory. So the objective list theory says there are things that are good for that animal. They may not know it's good for them, but I know it's good for them. And so objectively, I can measure that and say that even though they may not want it, it's going to improve their quality of life to get this thing. And there might even be a point of discomfort for them. So examples of that in the work that we do? Surgery, medication, vaccines, absolutely. So things we might do that we know are objectively good for them. Preference satisfaction speaks to that control. So if I can give them a choice, let me give them a choice and make sure that their preferences are actually met. So if they demonstrate what they like, I'm going to keep that in mind. And then hedonism, being in a positive state with absence of any negative feelings. As much as possible, I do want to provide a state of positive welfare for them, recognizing that these other things are going to play a role where there's not always going to be the ability to do that constantly. But ultimately, for the animals in our care, we want to try to make it as positive as possible. We already kind of talked about that, so I'm going to skip it. All right, so examples of proxy assessments for medical conditions in animals. Oh, I'm sorry you can't read that. That's really bad imaging. But if you're a veterinarian, we have these things for individual animals in a veterinary sort of setting. So they've been developing over time, but there's a 1998 quality of life for FIV cats that has been tested. Now, again, I'll remind you, all of these are proxy assessments, because if we were in human healthcare using human models for this, you would have the objective measures that the doctor reports, and then you would have the self-reporting of the person, and you would compare those two together, because the gold standard is the self-reporting of the person. In our case, these are tools. Sometimes the owner is the reporting person, and then the doctor is comparing measures. We have some for cardiac disease. We have chronic pain in dogs. We've had a couple recent, so if you're into this sort of thing, this is quickly developing. We have cat quality of life. We have one for renal disease, one for diabetes. There's actually a holistic cat quality of life scale. Remembering that these are really tricky to validate because we don't have gold standards. And then for dogs, there's cancer quality of life scores, skin disease, and spinal cord disease. So lots to look at in terms of individual health conditions from the veterinary standpoint. The ones that are more commonly used in owner sort of scenarios, or I have applied them in a shelter scenario, is kind of this holistic quality of life scale approach. So how many of you have seen this before? You may have used it for your own pets, just a few of you. Okay, so this is actually an older scale that came out in 2011 from Dr. Villalobos, who is an oncologist. So this is a 7-domain scale that she uses with pet owners to try and assess a pet's quality of life who is undergoing treatment for cancer or management for cancer. And so there's 7 categories, including hurt, hygiene, hydration, happiness, mobility, more good days than bad. And so you score them. She asked the owner to score them on a 0 to 10 sort of score, and then you add up your points. And if you are under 35 points, that's an unacceptable quality of life. And if you're over 35 points, that's an acceptable quality of life. Any comments on that? Any thoughts? Yes. Yeah, do I think it's applicable in a shelter setting? I think it can be. It depends on who you have as the proxy. I think the question for me has always been, and she doesn't really use it with that 35-point cutoff, but if you look at it, like that 35-point cutoff, what does that mean, particularly in a shelter setting? So what kind of monitoring do we have for hydration, for instance? Who's deciding more good days than bad? If you're having any bad days in a shelter, is that an acceptable number of bad days, right? Because the biggest difference is that for animals undergoing these challenges in a home environment, that is a consistent environment with a consistent owner that is invested in them and who can kind of really interpret their experience of the world. I think our challenge in shelters is that that may be a new animal in a new environment, and we may not be the best proxies. We don't have that historical knowledge. So does that kind of answer your question? I think it's a lot harder, and sometimes it may not work at all. Depending on whether we really think we can be a proxy assessor for that. And so I like this scale. I don't think it's particularly applicable. It's certainly not applicable to populations. It may be applicable to longer-term individual animals in your care, but ultimately I think it's the idea that is useful and not necessarily figuring out the math and scoring. There's another one that I really like from the Ohio State. This is, again, individual animal and mostly centered around euthanasia decisions. But what I really love about this one from Ohio State is it takes owners through a series of questions, and there is almost equal effort given to the physical health of the animal and the mental health of the animal. So there are many questions around whether the animal seems to still enjoy life, whether they are sleeping more than normal, whether they are dull or depressed, whether they're hiding. And so there's lots of elements in that that I actually have used. I have used this one in a shelter, specifically for long-term stay animals where there is a heavy amount of staff investment, but the animal is deteriorating. And so I had the staff fill it out, and it was an anonymous, sort of objective way for people to say that they had concerns about that animal's quality of life without necessarily feeling like they were being pressured by the rest of the staff or talked into something. And honestly, it led to a euthanasia decision in a particular case that stands out in my mind, where more than half the staff was like, this isn't acceptable anymore. Like, I love this animal, but this is not acceptable. So it can be a tool to pull out for that sort of individual animal investment that is highly emotional, if that's part of the work that you're doing with your staff to try to get to that point. Behavioral measures of quality of life. As a veterinarian, it's sometimes a lot easier for me I can look at kidney values and be like, these are bad. This probably means that quality of life is starting to be compromised, especially if I see behavioral changes. Behavioral observations can be a lot harder, but what we're really looking at is that animal acting normal for its species? Is it demonstrating abnormal behaviors like pacing, rocking, bizarre postures? Is it responding to environmental manipulations? Does it respond to enrichment positively, or is it hiding when there's environmental enrichment because it doesn't enjoy that type of activity? Are they avoiding staff and people? Do they have preferences, and are they going for those preferences? And so there's ways to set up behavioral observations in shelters to say this animal is behaving in a way that represents a good quality of life, or this animal is behaving in a way that doesn't have a good quality of life. I don't think I have particular slides to this effect, but probably most of you have seen a dog in particular demonstrate some sort of stereotypy where they're circling, or bouncing off the wall in the same place, self-mutilating. There's some research on that now. We've always considered that a behavioral emergency. In shelters, it often develops over time, so most of the time those dogs have stayed in the shelter for a while, have been in that enclosure for a while, have developed that as a coping mechanism. There's some recent research trying to decide if, as a coping mechanism, it's actually helpful for the animal to do that activity, or is it really just demonstrating that they are in a mental health crisis, which is how we've thought of it over time. I think the other thing that has been demonstrated is that animal, it's usually in response to the environment that it's in. Most of the time, if you get them into a different environment, they can improve, and so that's always been the intervention that we've worked for. But in some cases, it's so severe that they will continue to demonstrate it in a new environment. And that is where we say, this is really a mental health crisis for this animal. So much work to be done in behavior, so much good research happening. I'm certainly not the expert on that, but it is a huge piece of this quality of life concern, particularly for our long stay, highly anxious animals, or those animals who may come to us with large scale cases from unenriched environments, hoarding, puppy farms. I love that terminology rather than mill. Puppy farms, hoarding environments, those sorts of settings. For us, it's dog fighting cases where those animals have displayed behaviors, coping mechanisms over environmentally decrepit places that they've come from, and then what does it take to try and rehabilitate that, and can we rehabilitate those animals to provide a good quality of life? And sometimes the answer is yes, and sometimes it's no. Okay. The other thing about animals is they are absolutely individuals. So we can talk about populations, and I think on a population level, but they absolutely respond to stress differently. And I know that you've all seen this. Some animals cope really well with stress, and some don't. Some of us probably cope well with stress, and some don't. Some of this we're born with. So all of you can probably think about your stress management and potentially your family members and make some genetic connections there with how you might manage your life. It matters. Socialization. Lots of research in human infants around attachment theory and how we develop some of these stress behaviors pretty early. Same for dogs and cats. So critical socialization period to humans and kittens, 3 to 7 weeks. For dogs, 3 to 12 weeks. There is a period of time in there when they learn how to be cats and dogs, and they learn how to be with people. It doesn't mean if they skip that they absolutely won't come around, but some of those genetics, particularly for like long-term feral populations, they're probably not going to come around. So that socialization piece is important. They learn how to encounter the world. Personality. I think animals have personality. That was a radical statement 30 years ago. We've come a long way. I used to have slides in here I pulled out around, we used to think animals had no emotional life. Like that was just the way we thought about things. I remember when the first book came out about the emotional life of elephants, I was in my early 20s and I was like, what is this about? But now it's commonplace. I think most of you, once in a while I get a vet student holdout who'll be like, I don't think animals have emotional lives. And I'm like, really? Because the vast majority of veterinarians now will buy into that for sure. They have previous experiences, they learn. So from their stressful experiences, they learn how to respond or not respond. This is an important piece for what I think about in shelters. The duration of the stressor matters. So if I'm asking them to endure something for a long period of time, that's going to be way more stressful than a short period of time. And so I want to think about how to time things and be efficient to make sure that I minimize that stress and severity of the stressor. Not surprising. If it's something that's mild, they handle it better. If it's something that's severe, so if it's severe, it needs to be quick. If it's mild, maybe it can take a little bit longer. But those things matter because it speaks to how we do things and how we set ourselves up to accomplish our tasks. So I'll use an example again with vet students doing a physical exam. That can go on for a really long time and can be stressful. And they are so in their head about their own performance, like how am I going to do this physical exam? What are all the steps? That they will forget that the animal is experiencing that too and is equally, if not more stressed. I personally would be more stressed if I was that animal. And so there's this whole stage of training the students to be prepared. What are the things we're going to need? Let's get them out. Let's put them all lined up here. Is there anything else we need to know before we start? Do we have a towel to restrain this animal? Do we have a plan? What are we doing? Like, right? So that we can minimize the duration for both of them and try to minimize the stress of that event. And so that's the kind of thinking that I think we need to apply to everything we do with these animals in our shelters. And then do they have a coping mechanism? Do they have a hide box? I feel like I've been saying hide boxes for 12 years now, and I'll even walk into our partner shelter and there will sometimes be a cage without a hide box. And I'm like, have I taught you nothing? Like I just need to retire now. But they need hide boxes. Carriers for cats, paper bags, let's give them a choice. They don't have to choose it, but let's give them a choice. In terms of some of the behavioral things that we can monitor, we can look at urinary. So research is really looking at some of these indicators like urinary and salivary cortisol, the behavioral measures we've talked about, pacing, stereotypies, increased locomotor activity, vocalizing, lip licking, floor licking, yawning, pacing. I could probably show you videos and you guys would all pull that out. Yeah, that dog licked its lips, it's looking nervous. We've trained ourselves to be better at recognizing these things, but it is important to recognize that even the science on cortisol measures is not consistent. Different animals have different baselines, so even something that seems as objective as measuring cortisol. Animals have different baselines, they have different time periods when they may increase and decrease, and so none of these are as reliable a measure as some of the other things we can do, like stress scores, behavioral measurements, really monitoring our pets closely. And ultimately, which I've talked about a lot, we're going to get into tools in a minute, I come back to this. So Bernie Rollin was a philosopher who worked at the vet school in Colorado for years and years. He passed a few years ago, but he specifically worked on animal welfare, quality of life, euthanasia, as a philosopher, but worked in the vet school itself, which was really a unique sort of place. And his comment was that human cognition is such that it can value long-term future goals and endure short-term negative experiences for the sake of achieving them. Back to my marathon runners. There's probably periods of time when you're running that marathon that you're like, why the heck did I sign up for this? You trained for it, it was a big goal, you did it. You will put yourself through it because you want to get to the end. I am sure everybody in this room has some ridiculous level of pain and discomfort they have subjected themselves to for a goal. I used to use this ice climber mountain climbing example because I was like, what in the world? And then I went ice climbing and it's amazing and I love it. And so now I understand, but we do things like that because we're human and we can say to ourselves, I have a goal, so it's worth it. It's worth it to endure this moment. In the case of animals, there's no evidence, either empirical or conceptual, that they have the capability to weigh future benefits or possibilities against their current misery. They are living in the moment. And so it is on us to make that moment the best moment it can be, recognizing it's not going to be perfect. All of those things that we've talked about are challenges, but it's on us to do that because we have the goal that they're going to stay in our shelter another day because that perfect adopter is going to show up, or another month, or another 2 months. We may have that goal or that hope that that perfect adopter will show up, but the animal does not know that. The animal knows what they're experiencing today. And if we can't make that daily experience a good quality of life for that animal, we're failing them. And so that burden really is on us as their proxy assessors for how we make that better. And I always think of this on everything from like a medical procedure that I need to put an animal through where it's going to have to recover for a few days, to really thinking about those long-term stay animals and what is my ultimate goal in doing this? What am I thinking? Is this worth what I'm aiming for? And I think this has become more and more of a challenge as our shelters have evolved. And so we've evolved from sort of animal control facilities performing high levels of euthanasia to maintain that population out there in the world, to really driving down euthanasia numbers over the last 70 years. And what's come with that is now an increased expectation for what we do for those animals in our care, and that's come with increased expectation for what we do for our pets. And I think all of that's reasonable, but it has put us in shelters in kind of this weird position where we've got to figure out how to do more, maybe more for fewer animals, but it's not as though the challenge, the numbers of challenges have changed, they've just changed in type. And similar to the example I gave about how technology has improved and we can do sort of medical miracles and drive that care up, we have this similar sort of tension in shelters. So we can do more, but does that mean we should do more for those animals? Is it what they would choose every time? Are they communicating to us what they would choose? And are we listening or not? Are we focused on that long-term goal that we have, or on the goal that animal, they don't really have the goal, but what is probably best for them in this moment? And so this is some of the tension that can sometimes drive up our capacity in our shelters. We've got longer term stay animals. We are exceeding our capacity for care because they're staying longer, not necessarily because we're taking in more animals. But the tension is still the same in terms of the provision. We're going to spend some time this afternoon talking about senior and geriatric pets in shelters, and I'm really looking forward to that because I'm not going to talk very much. And other experts out there are going to talk a lot, which will be super fun. But absolutely, I know our intake numbers have changed for senior pets in shelters. I'm assuming that's true for you in Canada and some of your orgs that you are taking in older animals or potentially investing in older animals that in the past may have just been euthanasia decisions. And so we are definitely seeing some gray faces. I personally love them. I am a sucker for the geriatrics, particularly the small breed geriatrics. And we'll sometimes go to pretty extensive lengths for them, for sure, because there are crazy people out there that will adopt them. But at the same time, we have the tension that these guys come into our shelter, and can we give them the time? Or is it safe to give them the time? And so I always hold this up because I'm like, okay, these guys walk into your shelter, they need a significant investment and energy and time from your staff. Do they get the same level? Can we place them equally? It's almost always unfair that the angry little dog is probably more adoptable than the large breed dog, but there's safety concerns in that. It is rare that a tiny angry dog will maul you, especially because they probably only have 3 teeth left in their mouth, although that one has quite a few. They'll fall out soon, versus a bigger dog can really do some damage and is not safe to adopt. And so it's not all going to be completely fair, the world, unfortunately, but these are some of the things that play into role in these decisions. I'm going to skip through the ones that I went through in the first session, because that's, for those of you who were here, we talked about the 5 freedoms and then the 5 domains. And just to say that with this new 5 domains model, those measurable sort of practical pieces of health and environment all play into the mental health, and the mental health is being the most important thing, that we're really focused on that positive welfare state. And so we've talked a lot about individual animals. Now what do we do when we take an individual animal, we stick it in a herd? So we've got a herd of cats, we've got a herd of dogs. How do we start to interpret that entire population? It's hard enough to interpret the individual animal. We just spent a lot of time talking about that and all the complications. Super hard to create a quality of life tool for a herd that works for each individual animal. And so when we do these, we really do have to pull in all those various domains of the environment, the behaviors they're displaying, the resources that we have, how they interact with one another, and we don't have a perfect tool, but there's lots of work happening in this area. We can pull some stuff from other production settings. I like to say I am a massive producer of gently used certified cats, right? But so in production settings, like dairy farms or beef farms or chicken farms, welfare assessments often look for things like input measures. So what are the things that the animal is getting in terms of environment and resources? What are the things that we can do in our shelter? It also looks at the capacity, how many animals are there using those resources. And then the animal-based measures, which are what we've spent most of our time on, objective measures of things that we can see. And so we have there's applicability from those settings to what we do in shelters as well. But really in the shelter, it's about these things. Our population level quality of life relies on our facilities. They're a huge part of it. And so you can do good work in a really crappy facility, but you can do better work in a well-designed facility, and it doesn't have to be the Taj Mahal. If any of you have been fortunate enough to receive an email from me, some of you have, one of my taglines is from Temple Grandin, is that, I like fluffy pillows at nice hotels, but Motel 6 is adequate welfare. Temple Grandin said that in 2010 when she came to speak, and I loved it because I was spending a lot of time in Motel 6s at that point doing field work. I do like the fluffy pillows at my hotel this week, I will say. But the truth is that there's a certain level of standard, right? At a certain point, if you have a dysfunctional building, you can't have a functional organization. And so luckily, there's been a lot of capital investment in improving shelter facilities and a lot of work in industry to try and help with that too in terms of design. A better facility also helps you manage disease, behavioral and medical disease. In terms of prevention in our shelters, are you providing preventive medicine at intake? Do you have ongoing surveillance mechanisms? Are you looking at both medical and behavioral welfare in your shelter? Are you doing things like daily rounds, which I'll talk about in a minute? Do you have a system in place for recognizing pain and suffering, medical and behavioral? And then do you have systems in place that minimize your length of stay? Do you have pathway planning? Do you have an efficient way that animals can move through? Are you using your software in a way that provides communication between your teams? Are you outcome-oriented in your culture? Is there a sense of urgency to get the animals out? Or is there the belief that, oh, they're fine here? Because, especially if your shelter's gotten nicer, sometimes it can be easy to be like, oh, they're fine here. We have this brand new building, they're fine here. But they're probably not fine there because they're living there all the time in every moment. And most of these animals either want to be in a home because they have been bred and trained to be pets. That's what they are now. They are cats and dogs and rabbits, or they're community cats and they want to be back outside. They do not want to be with us. And so in both cases, we really need to remain outcome-oriented. And it's been this interesting dynamic that sometimes as facilities get nicer and shelters get nicer, people actually want to keep them there longer. And just because the place has gotten nicer doesn't mean you want to live at it. Most of you probably enjoy your hotel this week, but do you want to live there? You probably want to go home, right? For all the reasons you want to go home. Same sort of thing with our animals. And of course, in some cases, they don't tell us what they want. I love this. So you can make all the tools in the world, but yeah, are cats really telling you what they think? I truly do think they are. This is not accurate. I think this is more accurate. That yes, they can tell us what they want if we are willing to watch and interpret and if we know how to read their body language. And we're so fortunate. The work in this has been incredible. If you haven't completed the Fear-Free Shelters modules, I strongly encourage you to do that. They're free. They go over body language for cats and dogs. Oh, no, I won't say it again. And so we have things like this. If you are nerdy veterinarians and technicians and are interested in the pain scale I talked about earlier, we have a lot of work around facial expression and acute pain in cats. So this grimace scale, first tested in rats, I think. Now they have one for horses. We have one for cats where you look at different measures of their face in terms of their ear carriage and their squinching of their little face. This is all done in post-operative settings. And then you do a little scoring system, and they need pain meds. You can use this with your technician staff. Doesn't have to be a veterinarian doing this. Shouldn't be a veterinarian probably, because they should be doing other things. But figuring out how to use these sort of scales, and this applies in shelter settings. This is the Colorado State Pain Scale, so that can be super helpful, along with sort of those holistic quality of life pieces. How are we? Yep, okay. A couple of other things around decisions. So decision fatigue is a thing. So if you're tired of making decisions, it's real. There's an article in the New York Times about the fact that no matter how rational and high-minded you try to be, you will pay a price for too many decisions. It's mental exhaustion. And the more choices you make, the harder it gets to make those choices. And then you compensate in one of two ways. Guess what those two ways are? Don't make a decision. Anybody in that school? Or make a hasty decision, whatever's the easiest decision at the moment. And if it's like what you're going to eat, who cares? But if it's over treatment of an animal or euthanasia, that probably matters. And so we know that we need to figure out ways to make this decision-making in shelters a little bit easier. And so ways that we can do this is to build in efficiencies in our process. And of course, communication is really challenging in that. But from the ASV guidelines, I've already talked about this in the first session, it's things around resources, welfare, and mission, and making sure that the people who have the authority to make decision know what the resources are and know how those things work. And so I had talked about fast track and slow track animals in the earlier session, so I'll skip to the daily rounds piece. And so how many of you are doing daily rounds in your shelter? You might call them population rounds, you might call them MBS rounds. This is so important that if you take home nothing else, I really want you to take this home if you're not doing it. This is not medical rounds, and this is not inventory. This is a different process. So a medical team member, a behavioral team member, and a shelter team member, and sometimes operations, get together and walk through the shelter once a day and look at the status of each animal quickly and efficiently. Because you're doing it every day, you can be efficient because you're just catching up on the day before or new people. It is an opportunity to strategize around those pathways. What does this animal need to get out of here? How are we going to get them out of here faster? And I recognize that in some of your shelters, the adoptions person may be also the behavior person. The medical person may be also the operations person. Some of us wear more than a hat, but ideally it's not one person doing all 5 roles because that's a bigger problem. There should be at least a couple people who can walk through and make these decisions. And these are the questions that you're asking, like who are you, what do you need, what's your pathway, and how do we get you out of here faster? So that is one process for helping. What I will say about that is everyone says we don't have time. We don't have time. Anybody who buys into it and commits to it you have to commit for a couple of months and it needs a cheerleader, will tell you it will save you time in the long run. Because it's not just about I've checked on every animal and I'm moving them along their pathway. It's about I've also done a check-in with everybody was there when we did it. It's a communication point. It's an opportunity for people to understand challenges in other departments, and it's an opportunity to share problem solving. As a veterinarian, I always felt like figuring out the treatment was entirely on my shoulders. And then sometimes it was a matter of the adoptions person being like, oh, I've got an adopter for that. Or the foster person saying, I've got a foster who can handle that treatment. Let's get him out of here and into foster. And so it's a point of collaborative work. The communication piece is the secret that happens, but you've got to make it consistent and you've got to make it a priority. The other thing that can help with this is having a weekly, I call it a weekly welfare panel. There are other names for this, but once a week, it is a more developed version of daily rounds. So probably some of the same people that attended daily rounds, medical, behavioral, operational, plus or minus adoptions, plus or minus foster, sit down to talk about your long-term stay animals and to strategize about those bigger welfare challenges. So it's carved out time. Again, I'm all about efficiency in meetings. There are people who are really good at that. You move through those animals. You strategize about what needs to happen next for them. In some cases, this is a euthanasia conversation. In a lot of cases, it's a problem-solving conversation. But it keeps that animal on the list as a priority. They're still talked about in daily rounds, but often this provides a little bit more time because with any luck, it's fewer animals. I will wrap up with this and one more slide, and then we'll take questions. So key statements from the guidelines around this is that outcome-based metrics do not account for quality of life for animals still in the shelter's care. And so that was our statement, that it's not just about live release rate. It's also about quality of life in the shelters. Live release rates or save rates must be evaluated in the context of animal welfare and cannot be used alone as a measure of success. Aversion to euthanasia is not an excuse for crowding and poor welfare. These are all word for word, straight from the document. And long-term confinement of any animal who cannot be provided with basic care without inducing stress or compromising safety is unacceptable. Basic care includes daily enrichment and exercise. So these are some pretty strong statements that we struggled with, but we felt pretty strongly as a collective that we need to bring that quality of life piece up into the conversation, especially as live release rates have become such a focus for measuring success. But we know within our own work that there are other struggles to address beyond. Sometimes euthanasia is a humane outcome. As a veterinarian, I consider it a privilege to have that as a treatment tool when I need it to relieve suffering for an animal. And public health and well-being. Here are your statements around the people piece. So if you were in the first session, I talked about how we really worked to develop this. The ASV guidelines, ASV position statement now has a well-being statement. These are straight from the guidelines. Being able to provide appropriate care to shelter animals and seeing their quality of life improve as a result of that care reduces work-related stress for shelter personnel. In turn, personnel who are satisfied with their work are more likely to provide high-quality care for animals and stay in the workforce. Providing personnel with the skills, resources, and authority to excel at their job creates a beneficial cycle, improving human, animal, and population health. Mic drop. That is the last line of the guidelines. And that is the last line of the guidelines. And that is where I will stop, Linda, because I think we want to make sure we have time for questions. And I can talk. Yes. So frameworks for decision-making in shelters, and then how do we do that? Because we are sometimes empowering stakeholders and disempowering others. So I really do believe, so you can use, decision-making frameworks can take place in different ways. A lot of orgs are looking at sort of algorithms for medical and behavior and how you divide out. The ASPCA has sort of some decision-making guidelines around that. I think those can be helpful in terms of talking through a process, but I truly believe that one of the other things that can empower shelters is to sit as a group and come up with sort of an evaluation matrices. We used to call them pet evaluation matrices with the Asilomar Accords language, so healthy, treatable, healthy, manageable, sort of conditions ahead of time. So you sit as a group and you say, what are the animals that we can treat and adopt out easily? What are the conditions that we can treat reasonably and adopt out, both medically and behaviorally? And then what are conditions that we cannot adopt out easily? And do those need to go somewhere else? Do they need to transfer out? Is euthanasia on the table? And you do that both in medical and behavioral sort of conditions. And it is a group process that allows you to kind of work through the need to get to some sort of consensus, rather than needing to do that on an individual animal standing in front of you at that moment with all of those emotions rising and your decision fatigue and all of the other things. Yeah. Mm-hmm. Yep. So you are using one of those. Sometimes there are ones that don't fit the table, 100%. And the other one is the comorbidities. What if they have more than one condition? And so that is a welfare panel discussion then. So you know that you bring them in, you see what you've got, you're doing your daily rounds. It may be that decision can be made in daily rounds. Otherwise, it's a weekly welfare panel. That does mean both medical and behavior are playing a role. Most of the pet evaluation matrices I've seen account for comorbidities. So medical and behavioral is a good one. So if you've got a condition that, as a veterinarian, I might consider it treatable. I'll use an example of a hyperthyroid cat. So hyperthyroid cat, I learned in vet school how to treat that. So I can give you the list of the things you can do. You can go get iodine, you can get this methimazole, you can get this food. Fine. What about if that cat doesn't want those things? That cat tells me, I am not interested. For one, the radioactive iodine, maybe I can't afford that. Maybe the cat doesn't want to go sit in the hospital for 7 days. Maybe that cat doesn't want its daily methimazole or it has a reaction. My own personal cat did not. She chose that she did not want her hyperthyroid treatment. So I chose not to treat her, and she was happy till she wasn't, and that was a decision I made for her as an owner. I think of her when I think of some of these decisions. There are animals who absolutely tell us they don't want the treatment or they don't want to be in our shelter. And so we need to listen to that, and so that's what I advocate for in those cases. In some cases, we can't treat them. So if their behavioral situation has put them in a position where they can't be treated with what our medical treatments would be, then that is a decision that they're making that we need to essentially respect. That's my personal feeling on that. Yes?
Just talking to people, it seems like there are more and more big dog intakes,
Mm-hmm.
and there are more and more shelters struggling with decisions for aggressive dogs,
Yes.
physically healthy. Could you speak to that?
You want me to solve that problem? Okay. I left my crystal ball and my magic wand at home. So the question was, what do we do with all these big dogs? So we got big dogs coming in. We've documented longer length of stay for big dogs. Behavioral problems in big dogs are a bigger problem. This is an industry-wide problem. So what I can say is you're not alone. There are a lot of minds working on this. There was a big dog summit that Maddie's put on it was probably a year and a half ago now. There's continued research in the big dog arena for both why are they showing up. There's a lot of people interested in where are all these big stray dogs coming from in the US, because we don't have free roaming dogs in most places in the US. And then suddenly we have a whole lot of big stray dogs showing up. I don't have the magic wand on that. What I come back to with shelters is it does matter what our resources are. Do we as an organization have the ability to support that dog in our organization in a way that provides adequate quality of life? Are they able to get enrichment? So again, I'll go back to that statement. Long-term confinement of any animal who cannot be provided with basic care without inducing stress or compromising safety is unacceptable. Basic care includes daily enrichment and exercise. If we can't handle them to get them out, if we can't handle them to give them exercise and enrichment, then their daily experience is poor, and they don't have the goal of the magic adopter coming who lives on a hill with no friends, right? I think the challenge in this, Linda, and this is, the piece that's an unknown for us, is that we know some of those dogs will not be behaviorally unsound in a shelter, but actually will be okay in a home. We know that's possible, and that's what we cling to. But then what I say is we have to find an out of the shelter housing for them in a timely fashion, and it can't be prolonged. And in some cases, we just can't do that. We just don't have it. But they can't stay in our shelter. If we can't handle them safely, they can't stay in our shelter. Yeah. It's a great question. Quality of life for feral cats. A lot of that really speaks to the observational measures of their physical health. Because for most feral cats, behaviorally, they're happy where they are, right? They're in their natural environment. And so that for me is more observing what is their body condition score, are they physically healthy, what are the social stresses, are there enough resources in that place? And so there are some tools particularly designed for TNR programs for the cat that comes in and you evaluate it in that moment, can this cat go back out? And that speaks to the things I've talked about, body condition score, physical health. For dental disease is a big one. I'll get in cats that just have rotten mouths, and it's just not acceptable for them to go back out with that level of pain. And doing full mouth extractions may not be acceptable because that means long-term confinement. And so I don't think it's a magic secret, but there's this element of really looking at the status at which they come in and can they go back to where they came from.
Assuming that they
Yeah.
but we need to contain them for 24 hours before we stay in
Mm-hmm.
and possibly a week after. So it's in a sense, it's short term, but
Mm-hmm.
our organization is very concerned with their welfare during that period.
Yep.
Rightfully so, right?
So welfare during the time around surgery, again, let's make the stressor as short a duration as possible, and let's minimize the stressor as much as possible. And I would say minimize their stay as short as possible. So you're probably already doing what you can to make sure the environment that you're containing them in. Do I think it's worthwhile to put a feral cat through surgery so they can go back out and live their lives? Absolutely. That is a short-term stressor I'm going to endure. If I can get them out in a day or two, I prefer that over a week. Understanding some of them may need to stay longer, pregnant spays or that sort of thing, potentially, depending on your surgeons. But you're gonna wanna make it as mild as possible and as short a duration. And we're just doing the best we can because ultimately we think that their quality of life will be good. And so we're gonna put them through short-term discomfort. As a veterinarian, I have to do that all the time. Yeah, but I'm gonna make it as short as possible, yeah. Okay, we are over time, but we would love to see you this afternoon when you don't have to listen to me as much, but we are going to actually talk with an entire group of 4 lovely veterinarians about decision-making in their shelters around senior and geriatric pets. And no, they're not the same thing. So if you're interested in that, come on back.
Thank you so much.
Sorry, I ran long.
Interestingly, this was